Hello everybody, welcome to UroChannel. I hope you can hear me because I've changed something in my software and I'm not quite sure if there's any sound. I can see some of the measures going up and down, but I have deactivated the window for comments. So this is something that I can't see either, so I'm doing this blind. And here I got a message from YouTube. Jetzt live. Okay, great. I'm live with, what's that? Yep. It seems to work, at least. So YouTube just sent me a message that I am live. Sorry guys for the rough introduction, but I'm always kind of nervous if things are not happening the way I want them to. But anyway, as you can see, it's bright daylight. Unlike my other videos. I tried this because it's 8 o'clock in the morning, which may be late at night at your place where you are watching from. And as I announced earlier in my live streams, I just wanted to test whether I could be more fluent in English and more engaging than after a hard day's work, where I am always very tired when I explain things to you. And I think I am just more energetic now. So this is how I am in the morning. Everybody who's watching, welcome. Thank you very much for being a subscriber. If you are a subscriber, if you're not a subscriber, there's always a very good move to do in the morning. It's like gymnastics. You hover your mouse over the subscribe button and subscribe, because then you will get more of this content where I will deliver videos on urological, sexual, medical topics every Wednesday and Saturday, and there will be a live stream on Friday, and I will see whether this works better with a live stream early in the morning, so I might continue at this time of day. Then there are memberships. If you are a super fan, you can become a member. It's $1.99 to support my work, and there's a membership button that you can click on where you get access to memberships, and I'm planning something for my members which is coming up very soon, and I will send a message to you. So if you're a member, thank you very much for supporting me. Today's topic is about erectile dysfunction and realistic outcomes of erectile dysfunction treatments. This is something that's very important, because nowadays you kind of get the impression that it is very easy to treat erectile dysfunction, and this has to do with Viagra and Cialis, all the PDE5 inhibitors. That's the name for this class of drugs, and it appears that everybody's taking these pills and it is working. But I must say, if you are treating erectile dysfunction now and then, this may well be, because then you're not seeing that many patients, but I'm specialized on sexual medicine, and this means I'm seeing a lot of patients and a lot of complicated patients. So this is not only the patients from town who come to my office, but also from a very wide area, and these are indeed very complicated to treat. So it's an illusion to say we cover 100%, because we have to think about what can be effective, and if it is effective, does it match the expectations of the patient? So there are two sides of the coin. Like, it's me, the doctor, who may define success totally differently from my patients, because they want some kind of solution that I just can't deliver. So when we start with PDE5 inhibitors, here's a fact that's not very pleasant, because 30 to 35% of the users of these drugs, they have no effect. And that's a problem. Some of them don't have an effect, and I think this is the easy solution. They don't have an effect because they're not using them right. And this is something that happens all the time. So this is when I prescribe these kind of drugs, you have to think about two things, me as a doctor. So I always ask my patients, when are you having sex? because if they have sex after a meal, I have to account for that. Sildenafil Viagra is the first drug of its kind, which came out in 1998 and which revolutionized the world. It has a very important drawback because it interacts with the fat in the meal. So if you eat a fatty meal and take a tablet of Viagra, then the fat in the meal will bind to the drug, and it will then deactivate it. So you may not reach the levels that are needed for having an erection. So you need to cross a certain threshold, and this threshold is highly individual. So you can't say person A has the same as person B. It's highly individual, and you have to cross that barrier. Otherwise, you won't get an effect. This is problem number one. Problem number two is timing of the ingestion. If you have to wait for at least an hour. It's better you wait 2 hours until you have an effect. So if you are impatient and wait just for half an hour, you may not have the effect. So you think, okay, it's not working. Or people are so afraid of side effects. So what they do is they take a tiny bit of a dose, which is not working because you have to have enough, again, to cross that threshold, your individual threshold, to get an erection. And this is something that can be overcome by right dosing, by right timing, and repeated use. Because if it's not working one time, it may work the next time. And then you may also play around with dosages. But to start off, I'm a friend of maximal dosing. So you take the maximum what is allowed, just to test whether it's effective. If it is effective, then you can easily cut it in half and see whether it is working. But I kind of think it's always very problematic to convince somebody for example, who's afraid of side effects and the drug is not effective, and he's taken like sildenafil 25 or 50 milligrams, to convince them that they then should double the dose, and then they get so afraid of side effects they won't do it. And this is why it's psychologically it's much better to start off with a maximum. Then you have all the side effects that you can get from the drug, and if it's working, you can just lower the dose. And speaking of side effects, it is not for certain that you will get side effects. I think this is one of the biggest misconceptions when it comes to pharmacology. Side effects may happen, but you're not having them automatically every time you're taking a medication. I have lots of patients who are on PDE5 inhibitors who never experience any side effect. And you have to keep that in mind. It's also a personal thing. And therefore, if you look at the prescription and the information that comes along with the drug, there are risks of side effects. So, like for example, stuffed nose or headaches. This is something that happens very often, but it doesn't happen in everybody using these drugs. So it's just something that happens to many people. And you have to see whether you react to them in terms of side effects or not. And this is something that applies to every drug. So you have to keep this in mind. It's not for certain that you get side effects from a drug. And besides, side effects from PDE5 inhibitors, they may be unpleasant, like headache, stuffed nose, flushing. Tadalafil will cause back pain in 3 out of 100 patients. This is not dangerous. So you mustn't be afraid about them. But as a rule, you don't want to use these drugs with a certain kind of alpha blocker, or especially not with nitrates. Nitrates are medications which are used for angina, which is heartburn. And if you have these drugs, you wouldn't want to use PDE5 inhibitors together, because they may cause your blood pressure to drop, and then you have a risk of dying. So the risk is too high. So then you have to work around this. But as I said, 30% are not responding. Once they're not using them right, then diabetics always have more difficulties in achieving the levels or achieving an effect from this kind of drugs. If you have severe cardiovascular disease, they may not be as effective as well. I think also if the penis has changed in its structure when you cross a certain age barrier. So usually it's 60 years, then I constantly see less pronounced effects from any kind of treatment. And people who are older than 60, rehabilitation is more difficult for the body, obviously, and this is also what the studies show. Like if you remove the prostate for radical prostatectomy, then rehabilitation is much worse in people over 60 than under 60, and it applies pretty much to everything that you do to the body. It just takes longer time, and it's not rehabilitating that well. And if you cross the barrier 70 years or even 80 years, the penis suffers from structural changes just because of aging, and you have to be aware of that. And this may have implications for the efficacy of a drug that you use. So PDE5 inhibitors may not be that effective because structural changes have occurred. So you have to work around this. And now we have to talk about things that people expect. So what do they want? And very often they want to have a treatment for the cause of the problem and rather for the symptoms of the problem. And this is sometimes not so easy to bring about, especially in patients who are non-responders of PDE5 inhibitors. So if we're talking about causal therapy of erectile dysfunction, this is kind of the specialty that I'm doing. It's regenerative therapies, where I started off with shock waves 8 years ago when I opened my office. And over the time, I added up with the P-shot, which is platelet-rich plasma, and I also have the magnetotransduction therapy, EMTT, and I combine these. So this is where I ended up right now, that I combine treatments in order to get the best out of each world. And it works, I have to say that, and in some patients it's really, really astonishing how well it works. And then in other patients I really get frustrated because nothing moves. Even after 2 months, nothing is happening. And I haven't quite figured out why. Because these are not only older people, they are also younger people. And this just reminds me that treating erectile dysfunction is difficult. So I can't guarantee any kind of treatment success. That's what I tell my patients, because sometimes I just don't see any effects, and I feel really sorry for this because I'm frustrated, the patient is frustrated because nothing's working. But what these regenerative therapies do is they restate blood vessels, they activate stem cells, they work on nerve integrity, so the nerves are working better, and they work on structural rehabilitation of the cavernous bodies of the penis. So all of this may result in much better erections. And I would say if it's really working, the best patients I've seen, they increased by 7 points in the International Index of Erectile Function, the IIEF-5. This is 5 questions, 5 points each question, so it's 25 points max. And 7 points is quite a lot, so it can make the difference from having a mild to moderate erectile dysfunction to moving up to normal erectile functionality. Then, if this is not working, then we have to talk about other means of erectile aids. And the oldest one that is around is a vacuum pump. And if you watch UroChannel and have watched my videos on pumps, you know that I am not so happy about them because there are largely unknown but obviously present, there are side effects to pumping. So I would say if you have severe erectile dysfunction, it's safe to use a vacuum pump. If you want to use a vacuum pump for the means of penile enlargement, I would really caution against it, because you may damage your penis. I don't think that this damage is so much pronounced if you do it, if you have severe erectile dysfunction, because you can't do anything wrong, right? Because the penis is not reacting. But if you are fully functional and want to increase the size of your penis by pumping, it appears that there can be damage. I think it's to nerves. I did a video about this, to the penile nerve. And then I had some patients last year who did pumping, who did jelqing, where suddenly like there was a popping sound or some crazy move, something that happened inside the penis, and they were going from fully potent to impotent in a fraction of a second because of jelqing and pumping. And when I posted the videos, I got some comments from other users saying, well, listen, this happened to me as well. I don't think it happens very often. I think it's a rare side effect, but it happens. And I, as a specialist, I see concentrated all these accidents. But if you want to use a pump for penile enlargement, I don't think it's worth the risks. Especially because, like, if you're going from this to this, I don't think anybody will notice, and therefore I'm very skeptical. But as I said, for erectile dysfunction, it's the oldest aid in the world to help with erectile problems, and it's working. Drawback: you have to place a ring at the base of the penis, which then will constrict the penis because you have to keep the blood inside, and you have to remove the ring after 20 minutes or so, because then it starts to hurt, the penis becomes blue, and then you want to end this. But if you are used to it, if you have mastered the technique, then pumping is really not a problem. The other thing that you can do, which is very effective, is injection therapy. In the US you have Trimix, which are 3 drugs mixed together. There's a special pharmacy in Germany where you can get this. In Europe and Germany we use other stuff. We use alprostadil as a monotherapy, and at least in Germany we have gotten a couple of years ago Erectile, which is another kind of drug, and I use these two interchangeably. For some reason, if you use alprostadil after radical prostatectomy, some people really get pain with the erections. A painful erection, I would say 90% of the men. But if the prostate's still in place, it's absolutely painless. And I haven't seen these effects in prostate cancer patients with Erectile, so I have a tendency to prescribe Erectile if it's available. We have shortages on medication all around, and you never know what can be bought and what cannot be bought. And sometimes I have patients who look for pharmacies all over the country just to get the medication. It's very difficult sometimes. And Erectile is one of those drugs which are difficult to find. Problem with injection therapy is you have to stick a needle into your penis. And for many men this is a horrifying thought, but really it's not a big deal, because you have to do it in a place where it doesn't hurt. And I have a special area where I apply this, and it's more like people are very they are what's the name? Sorry, it's not late in the day. It's early in the morning, but I'm still lacking a name. Surprised, yes, that's what I was looking for. People are rather surprised when I stick in the needle because it didn't hurt at all. It's a very small needle. It's very little, and if you're using glasses, without glasses you wouldn't hardly see it. So that's not a problem. Problem with injection therapy, it may cause permanent erections, which is something that's dangerous. And this is called priapism, when the erection doesn't go away. So dosing is very important. And scarring may be a problem. When you look at the literature, Trimix seems to be more associated with scarring than Erectile or the other drug that I'm using here in Germany. And scarring may cause the penis to bend. And this is something that can happen if you do this often. The papaverine, that's the drug that's obviously linked to more scarring. But then we'll see. So I get a message. Let's see if I have sound. Okay. It obviously seems to work. I have a double check that my live stream is working, but I can't see any comments. Sorry guys, I have to look it up next week, what is happening. I won't explain what I changed in my setup, but I had to announce my live stream for today, and this caused my software to mess up for some reason, so I have to deal with it the next days and see if I can fix it. What else can we do? Yeah, you can use a ring instead of a pump if you have some erectile function left. Then you can use a ring to support the erections. That's also working. Or in severe cases, you can even combine. You can combine PD5 inhibitors with injection therapy or a pump. These are therapies which are possible. What else can we do? Yeah, we could do a prosthesis. That's if nothing helps and you really want to have an erection, you can place a prosthesis. And this is it looks like a zodiac boat, more or less. So you have to pump it up. It's placed inside the corpora cavernosa. It's an operation that's we have it standardized, so it's not that much of a big problem. And you get a reservoir with fluid that's placed in this small pelvis and a small pump that's in the scrotum. So you can, with the use of this pump, you can fill up these zodiac boats and get an erection within seconds, because then fluid from the reservoir is guided into the rods of the prosthesis, and then you will get an erection. And when you are done, you just have a small button that you press, and then the pump is released and everything flows back into the reservoir. So this is a very beautiful solution for a severe erectile problem. I think in the US it's different. In Germany I don't see that many pumps, and many men shy away from using them. In my opinion, the problem is that it is something that's subject to wear and tear. So if you're a younger man, then placing a prosthesis will mean that you will have to replace it. And depending on how often you use it and how long it is in place, then you will have to replace it. I think after 10 years, maybe sooner, maybe a little later. And this is another operation. And once you have been operated, redoing surgery on an area where surgery has been done is always more complicated, because the body reacts to placing stuff, it reacts to having cut in there, so you have the scarring. It's more complicated to replace a pump. Then there are also problems with infections. You have to be really careful not to get an infection, but pump and prosthesis infections happen, so you have to take this out. Then you have to wait for many months, so it's a mess. If problems happen in prosthesis placement, around prosthesis placement, in breakage of prosthesis, I would say it's a mess. And you wouldn't take these complications lightly. And this is what I see with the greatest drawbacks in prosthesis. But if they work beautifully. But as I said, there are some articles about complications that can happen. I have linked them to one of my videos I did about prosthesis. If you're interested, it's not so long ago that I did a video about it, where I also have linked some literature, because some images I must not show on YouTube, and this is science, so you can just look up the images in the scientific articles that I have linked there. So this is basically it. But as you can see, as a whole, it's not very easily done. And then I didn't mention the psyche, which is very powerful. And psyche can be so powerful that even injection therapy is not working, because people get so anxious about to perform that it just doesn't work. And you always have to consider the psyche, which is, in my opinion, it's always involved in more or less, so to speak. Sometimes it's merely psychogenic, but what I see happens very often is that men get very uncertain about themselves once they have experienced their erections failing. If this happens 1 or 2 times, then you get very insecure about yourself. So next time you go up for having intercourse, you think, oh, okay, is it working today or is it not working? And this insecurity triggers your sympathetic nervous system, which will then activate electric impulses through your nerves, which inhibit the erectile function, and then you won't get an erection. So this is usually how it starts and how the psyche comes in when physical features set in. I get another message here. Okay, yes. There's one point that I also have to mention. If we're looking at erectile dysfunction, and this is what I'm also always assessing, that's the whole sexual cycle. And we have some models of how human sexuality functions, but roughly you can say there's sexual desire, where everything starts with. Then we have sexual arousal, we have erection, we have the orgasm, ejaculation, which is usually the same, but it can be divided. Then we have pain and all the rest. And if you look at erection, you have to keep in mind that this is embedded into this sexual cycle, which means if you don't have sexual desire, then it will be very difficult to achieve an erection. Erections are facilitated by by wanting to have sex. If you don't have that and you command your penis to get an erection, this is not working. So you have to be in the mood for sexual activity, otherwise it's not working. Now you're asking, okay, what about erections at night? What about daytime erections? These are physiologic erections because the penis needs erections now and then. Because if it's not erecting, then there is too little blood flowing through the organ, which then means it's kind of suffocating. So there are cells in the corpora cavernosa which will then die. This is the situation that you have after radical prostatectomy. So the penis will suffer, and then eventually you will have a venous leak. That's the only mechanism that I can think of where a venous leak can happen. Stuff like that, by the way. But this is not today's topic. If the penis is not working, or if you don't have these erections, then the penis will suffer, and then it will stop working properly. And then if you are sexually aroused, it wouldn't happen. So you have these erections at night. This happens during REM sleep, when you are sleeping and dreaming. Then you have these automatic erections because the parasympathetic nervous system is taken over, and the sympathetic nervous system is shut down in these situations. This is why you have erections at night. And then as a young man, you have these daytime erections, which are very rare once you pass a certain age. They kind of disappear. And I always see these confusions in men when they wake up and they have an erection. They have no idea why this is happening. And many men are under the impression that this is a sign the body wants to have sex. And I can assure you, no, it's not. It's just a physiologic thing. So you have to separate these, and also separate these daytime erections. I gave it a long thought because I constantly have patients telling me the erections have gotten worse, and when they go into town and they see a beautiful woman, they don't get an erection anymore. And I'm not quite sure if this is an attribution, because if you get if you don't know about these mechanisms and you get an erection which is spontaneous throughout the day and you have no clue why this is happening and you think you get erections only if you're sexually aroused, then you look around and try to make sense of this. So you see a beautiful woman and you think, okay, this because I saw her that I'm getting an erection. I think this may be one of the things involved here. But you have, like for spontaneous erections, you have to be sexually aroused. And this is the reason why PDE5 inhibitors don't work automatically. PDE5 inhibitors only work if you're sexually aroused, because they don't interfere with sexual desire. And if you're thinking that, I'm sorry to tell you, it's not working this way. So it's a blocker of phosphodiesterase 5. Phosphodiesterase 5 is an enzyme. And this enzyme is involved in the smooth muscle of the corpora cavernosa relaxing. So PDE5 deactivates cGMP, which is cyclic guanosine monophosphate. cGMP, yeah, monophosphate. And this is the enzyme which then relaxes the smooth muscle inside the penis, so you get an erection. And if phosphodiesterase, which is breaking that down, which is when you block that, then the process will go on and you will have an erection, or it's facilitated, but only if there is a nerve impulse from your brain telling the penis to erect. And if you don't have that impulse because you don't have the sexual desire, then you don't get an erection. And again, you can see how the mind works together with the body, because you have to have this thought, you have to have this feeling of sexual desire to generate a nerve impulse, which is then not psychological, this is then physical. You have transformed psychology into a somatic impulse, which is then going down to the penis and causing the penis to erect. So it's intriguing stuff, it's very interesting, but it's also very complicated. So, what's the time? So 10 minutes until my next patient arrives. So maybe I can tell you something about the venous leakage, nevertheless, because it belongs to erectile dysfunction and it belongs to complicated erectile dysfunction. Just generally, I'm a specialist in this stuff. I've read a lot, and you bet I've read a lot. But I've not understood the venous leak. I don't know what this is. So it's only one instance where I understand how this works. This is, you have to look at the function of the penis, the function of the organ, and what's basically doing is that you have the corpora cavernosa, which are inside, and they are composed of smooth muscle, and if relaxed, they're contracted. As you have to think it through, because if you think of muscle and you think of contraction, it's totally the opposite of what you may think. So a relaxed penis is contracted, so it relaxes when it's activated. It's the other way around. And around these corpora cavernosa, there is a very formed structure which is called the tunica albuginea. And between the corpora cavernosa and the tunica albuginea, there are the penile veins. So if the pressure rises inside, then the veins will be compressed against the tunica albuginea and the veins will be closed. That's the hydraulic mechanism that's behind erectile function. If you have a venous leak, then blood travels into the penis and then it immediately goes out through the veins. But this is not a problem of veins. It's a big misunderstanding. The veins have nothing to do with the venous leak, because they're just the tunnels where blood just disappears. The problem is that they don't close, and they don't close because the pressure is not enough. The pressure between the corpora cavernosa, the inside, and the tunica albuginea. So there are two possible reasons why this may happen. Either there's not enough pressure inside, or the tunica albuginea is too floppy. So if it can't withstand the pressure, then the veins would not be closed off. And as I said, the only instance where I can understand how this works is with prostate cancer patients who have been operated, where the prostate has been removed and they don't get any erections for a prolonged period of time after 1.5 years, then the situation inside the corpora cavernosa has deteriorated to a point where they have shrunken, so they are smaller, but the tunica albuginea has the same size, so a smaller corpus cavernosum then meets a normally sized tunica albuginea, and then when the pressure rises inside, it can't exert that pressure onto the veins, so the veins stay open, and then we have a venous leak. But how could this happen in a young man? How could a 28-year-old have a venous leak? I have no model why this should happen. And even if we think about a floppy tunica albuginea, why should that happen? And this is a collagenous structure, so we're talking about collagen. So what I then would demand would be that where else in the body is a collagen problem? Because it can't be isolated in the penis. And this is what I don't understand about this condition. And I think it is diagnosed all too often, because I think nobody has figured it out. If you look at the literature, there's no article explaining this to me where I can say, okay, now I've understood how this works in young men. So I'm still fumbling around with the venous leak. And sometimes if you use injection therapy, you can use this for diagnostic purposes. You have a patient, put him on a bench, then you inject him with Trimix or Alprostadil, and he's not getting an erection. And you measure him with your ultrasound, and you see, okay, blood is traveling in, it's beautifully, but then it travels out. You can't base a diagnosis of the venous leak on this examination, because again, the psyche may play a very important role here. So if this is a very embarrassing moment for many men, so they lie more or less naked, exposed on a bench. So a male doctor injects them with a needle. That's very embarrassing, and then they're expected to have an erection. So the psyche can override this easily. So if you're very tense, you may not get an erection. Then the doctor says, okay, you have a venous leak. But it is not, it's just the psyche interfering with the drug. And so this is why I never base this kind of diagnosis on a test like this. You can do an MRI, which is rarely done. I think there are 1 or 2 units in Germany who are doing this kind of examination, and even then I don't really understand. And the worst thing that you can do is then to go ahead and do a venous surgery on veins. As I said, it's not a venous problem, it's a problem of the whole system. So what happens is they close veins surgically. By the way, history is repeating itself, and they had this idea back in the 70s. They did that, and they found out back then it's not working, because after a couple of weeks the same problems, they reappear. And this is why they abandoned it. So new doctors coming, the young doctors think, I have a brilliant idea, I do venous ligature. Because they wouldn't listen, or they've never heard about this, that it didn't work back then. They think it works now. Now it's not. It's still not working. So I see lots of patients who have been operated, and then they come back after 3 months and turn to me and say, well, I've been operated, but it's not working. It worked beautiful in the beginning, and then it just stopped, and I'm back to square one. And this is a very, very complicated kind of disease which I haven't figured out. And you know, what you haven't figured out, you can't really treat. You can try to use rings and injection therapy and try to work around that. That's very complicated. And while I'm speaking, I have 4 minutes until my patient arrives. There's one thing I didn't mention at all, and that is the soft glands syndrome, also called cold gland syndrome, which is a very special form of erectile dysfunction. And this is not linked to the corpora cavernosa, it's linked to this corpus spongiosum, which is the tip of the penis, and the corpus where the urethra travels through from the bladder. You may think this is not so important, because stability or rigidity of the penis when you have an erection comes from the corpora cavernosa, although this is where we are focusing on. But in certain instances, you can have an isolated problem with the tip of the penis, with the corpus spongiosum, which is then called soft gland syndrome, because it's not erecting. And this compromises stability of the penis a lot. So even if you have normally functioning corpora cavernosa, the tip of the penis is not hard, it will get wobbly and it will interfere with intercourse. And this is one of the very big problems to treat. So you can try injection therapy, and then it's painful because you have to inject it directly into the tip where you have all the nerves. I don't have patients who like this. So this is a problem if this happens. I get another comment sent from my... Okay, I'm reminded to end this right here, right now. So if you have some comments, just write them beneath the video. If you haven't subscribed to UroChannel, subscribe. If you haven't become a member, I would be pleased if you became a member, if you like my channel. I got a message from YouTube today, and this may be interesting for all the other guys who are not native speakers or who don't understand English that well. YouTube has introduced dubbing of content, and my channels will soon be released for it will be rolled out on my channels that dubbing is enabled. So if you want to watch my content in other languages, it will be possible soon. What I've heard is that the dubbing function wasn't that good right now, so it may dub funny things. I'm very excited to see what's happening. I have some channels in other languages where I post videos once in a while, and I've done one thing that I didn't mention at all. Maybe I do this next week. I have an avatar, and I've one video on UroChannel, and one of you noticed that I was an avatar. So you just have to go with the flow, and I'm trying avatars and stuff, but I'm not an avatar. And you can kind of see when it's an avatar, but it's fascinating technique. It's almost normal looking, and the voice is very good. It's very close to my own voice. It enables me just to write a script, and then I don't have to build stuff, and it's for fast content creation. It may help. It's very funny to use, so check out my last videos. I think the one of the prostate was done by an avatar. Okay, thanks for watching. Drop a comment if this is more convenient for you time-wise. I feel much better talking early in the morning than in the evening, and then it also gives me a free evening. So drop a comment if you want me to continue in the mornings, Central European time. Have a nice day, have a nice evening, have a nice weekend. See you next week. Bye bye.